After what seems like forever of discussing the cardiovascular system, we finally get to move on to some new topics. However, with that being said, I can't stress this enough that as we move through the subsequent systems now, respiratory, urinary, endocrine, we are going to be constantly coming back to at least some aspect of that cardiovascular system, as a lot of the systems that we will have moving forward have a lot of overlapping function. As part of our respiratory discussion, we'll talk about gas transport throughout the blood. And when we get into the respiratory rate regulation, we'll be talking about things that are measured in the blood as chemical markers, oxygenation levels, carbon dioxide levels, and even the pH of cerebrospinal fluid. But for today, we get to stick strictly with respiratory anatomy. We'll be looking at the respiratory system in an upper and lower respiratory tracts, and then we'll be spending more time on the lung tissues themselves. Now, anatomically, we divide it into an upper and a lower. Functionally, we'll be looking at the respiratory system as a conductive versus respiratory portion. Now, these are not using the exact same landmarks as we divide up each of these two different ways of looking at the respiratory system. You will see that the upper versus the lower is going to be made just as we move into the larynx. So essentially, as we separate digestive anatomy, potentially, from respiratory, we've got the nasal cavity, which will be respiratory. We got the upper part of the pharynx, which will be respiratory. But once we get down into the oral pharynx, we have some overlapping anatomy between digestive and respiratory. But once we get below that point, the larynx, trachea, and down into the bronchi, we are purely into respiratory system. So as we pass the larynx, we are getting into the lower respiratory tract with no overlap with the digestive system. With regard to functions, obviously we are going to be sticking with ventilation and gas exchange primarily. Ventilation meaning the moving of air into and out of the lungs. Inhalation, exhalation. Gas exchange is going to refer to the crossing of carbon dioxide and oxygen across the epithelial linings of the lungs. As we breathe air in as part of the ventilation process, we do have a certain degree of gas conditioning. We'll be passing that gas through the nasal concha. If the air is too cold, it's going to help warm that air before it hits the more delicate areas of the lungs. If that air happens to have particulates in it, the nasal cavity with the hair and whatnot, and the ciliated columnar cells of the upper respiratory tract is going to help remove those particulates, again, to keep them from getting down into the more delicate tissues. We'll use the respiratory tract for sound production. Now, we can divide sound production up into two different ways. If you remember when we did neuro, you would have talked about Broca's area, the part of the brain that controls the muscles associated with speech. So when we say sound production, we could be using the larynx and the voice box, as well as, I guess, the digestive organs of the tongue and the lips to form specific sounds as they would be associated with language. But we will also use the respiratory system to produce the other sounds that we kind of discredited or disregarded back in neuro, the moans, groans, grunts, and squeals, as just by moving bulk air through the respiratory system as a whole, without needing to refine it into specific sounds associated with language. We'll use the respiratory system for olfaction. We talked about particulates in that inhaled air just a moment ago, and I guess the way I alluded to it at that point, it would be as if they were dust, smoke particulates. You don't want it to get into the deeper parts of the lungs. But we use very similar particulates as a way of sense of smell. That's going to be sensed in the nasal cavity as part of that olfaction. And defense. Remember, the deep linings of that respiratory system, and even up through the trachea and upper nasal cavity, is going to be covered with epithelial tissue that has to form some degree of frontline barrier as part of the immune system. Remember, anything that's going to infect the body has to cross an epithelial lining, and the epithelial linings of the respiratory system turn out to be rather vulnerable to that. We'll start at the upper respiratory tract, work our way down into the lower respiratory tract through the conductive portions of the respiratory system, and then finally we'll talk about the respiratory portions where we actually see gas exchange. So as far as the upper goes, we'll be looking at the paranasal sinuses, although we won't really be focusing too much on that. As far as I'm concerned, that was a skeletal feature that you covered in A&P1. We'll look at the nose and the nasal cavities and the pharynx. Now, all of these are going to be viewed as conductive. We mentioned the separations earlier, conductive versus respiratory. No gas exchange will occur in the nose, nasal cavity, or pharynx. So this is all conductive anatomy that also happens to be part of the upper respiratory tract. The paranasal sinuses are generally paired: frontal bone, sphenoid bone, maxillary bone, and the ethmoid bone. They are hollowed out cavernous regions in that bone that will take on a number of different functions, from changing the sound quality that's being produced to helping condition the air, all the way up to making the cranial bones a little bit lighter, decreasing their mass. Now, we'll be looking at the terms here, but for the most part, we're going to be sticking to a lot of diagrams. Hence the reason that we're back out of the classroom format again this time. You will see certain topics that tend to be more anatomical. And we want to see the features up close. We'll do it on the screen. The nasal cavity itself is going to run between a set of landmark borders, and we are going to be real big on those borders for this particular section. The nasal cavity itself will run from the rim of the nostril all the way back to a ridge of soft tissue at the back of the nasal cavity called the conae. In the nasal cavity is where we will have our superior, middle, and inferior nasal concha, increasing surface area for any air flowing through that nasal cavity. Again, gas conditioning. We run that air over the surface of the nasal cavity, conditioning the air, removing particulates. If we can increase the surface area of the nasal cavity, we will get a more effective gas conditioning, and that's what we see in the nasal cavity. Now, as we move posteriorly, you will see that ridge, and you don't get to see the ridge on the drawing here quite as well. So if we move to a cadaver specimen, you can see where that ridge of tissue is going to sit at the posterior aspect of the nasal cavity, being the conae. Once you pass through the conae, you are moving from the nasal cavity and into the most superior portion of the pharynx. The most superior portion is the nasopharynx. We move inferior into the oropharynx, shared anatomy with digestion. And then finally down into the laryngopharynx, also shared anatomy for digestion. And it's just below the laryngopharynx is where we will have our fork in the road, so to speak, between continuing on with respiratory down the trachea or moving through the more posterior aspect through the esophagus and into the stomach. We said the posterior border for our nasal cavity was the conae. We can mention the conae again here now, as it is going to be the superior or anterior border of the nasopharynx. The nasopharynx continues down to the tip of the soft palate. It's important to realize that we use this landmark when the soft palate is relaxed. When we discussed this as part of the cranial bones back in A&P1, we said we had this horizontal portion of the maxillary bone, forming the roof of the mouth. We had our palatine bones making the posterior aspect of the roof of that mouth. So if you put your thumb up on the roof of the mouth, it's a rigid structure supported by bone. That's the hard palate. Once we move posterior off of the palatine bones, though, you have what we refer to as the soft palate. Here would be the uvula as it dangles down. Now that is a functional set of tissues. It's important that we direct any swallowed food into the posterior aspect of the oral pharynx and down the esophagus. We do not want food going into the trachea. We'll get to that in a moment. And we don't want food heading up into our nasal cavity. So as we swallow, and again, a digestive topic right now, but you chew, and you form a bolus of food. The first phase of swallowing is purely voluntary. You take that bolus of food and you push it up into the roof of the mouth. And then by actions of the tongue, you drag that bolus of food back along the hard palate onto the soft palate. And along with some muscular activity, we elevate that soft palate to seal off the opening heading up into the nasopharynx, preventing food from moving superior. So we use the border of the nasopharynx as the soft palate, but only while the soft palate is relaxed. It's one of those things we always have to make account of whenever we're using a movable piece of anatomy as a landmark border. We do have a set of tonsils associated with the nasopharynx. We have our pharyngeal tonsils, otherwise known as the adenoids. Those are going to be located more so up into the superior lateral aspect of our nasopharynx. So as we breathe in, particulates move over the adenoids with the potential to pick up particulates and recognize early on any foreign invaders that were in the air that you just breathed in. We also have the openings to our auditory tubes or eustachian tubes. Remember the middle ear that we discussed back in A&P1. We use these auditory tubes to drain fluid from that middle ear. It'll drain into the back of the throat and ultimately get disposed of as it drips down the back of the throat and into the esophagus. Lined with pseudo-stratified, ciliated columnar epithelial tissue. Remember, these cilia project off the surface of that columnar cell like fine hairs into the nasal mucosa. Any particulates that are dissolved in that mucosa now can be worked towards the outer respiratory tract and be disposed of. So we move past the soft palate, now we're into the oropharynx. Same inferior border we had for the nasopharynx now becomes our superior border for the oropharynx. We have the tip of the soft palate while it's in its relaxed state. Now here we have another brand new border to deal with, the fauces. The fauces are going to be a pair of tissue arches that's going to separate the oral cavity from the oropharynx. So we would see the fauces extend right down through this region here. Now obviously not a good view of them on this diagram, but if we look at this other drawing, we can see these pairs of arches extend down the lateral aspects of the back of the oral cavity. Once you pass through those arches, is going to be crossing from the oral cavity and into the part of the pharynx known as the oral pharynx. We also have tonsillar structures associated with the oral pharynx. We have palatine tonsils sitting in between those paired arches of the fauces. And we have lingual tonsils associated with the posterior aspect of the tongue, lingual meaning tongue. And while we're on this diagram here, it's a good opportunity to show the openings of those auditory tubes as they extend back into the nasopharynx. Now we get down past the oropharynx, we continue inferior now, and now we're in the laryngopharynx. Now our borders here are going to be anything below the hyoid bone. So that hyoid bone, again, when it's in a resting position, is the border between the oropharynx inferiorly with the laryngopharynx just below it. Again, as you swallow, the hyoid bone moves up and down slightly. We want to make sure that we're using that border when it's in its relaxed state. We move past that point, and now we move from upper respiratory into lower, but we're still going to maintain that we're in a conductive portion for the time being. We have to get rather deep in the respiratory anatomy before we move into what we call respiratory portions. Remember, those are only going to be for gas exchange. So we remain in conductive as we move through the larynx, trachea, bronchi, and bronchioles. Lower respiratory tract, but still conductive anatomy. It's not until we move past the bronchioles that we're into respiratory bronchioles, alveolar ducts, and alveoli before we consider to be respiratory tissue. Now, as we move through these, you'll see this is a branching network. So we start with a large singular trachea, which will branch into two primary bronchi, which will then branch into several bronchioles. So it's like looking at a tree tipped upside down with one trunk, and the branches keep getting smaller and smaller and smaller until eventually you reach the alveoli, which in this analogy will appear to be like the leaves on the tips of the branches. So the most superior part of that lower respiratory tract is the larynx. Now, from a layman's term, the voice box. This is the piece of anatomy that helps manipulate air for the purpose of producing sound primarily. Air has to pass through it. There's no way around it. So as the air passes through it, we can constrict various parts of the larynx and manipulate that sound as it passes through. Now, of course, for the production of speech, we need some rather fine control over those muscles. And that's where we can get back into Broca's area, controlling those muscular tissues. We will also see the larynx become an important part of the coughing and sneezing reflex. It helps us build up pressure in order to achieve both of those actions. It's going to assist us in increasing interabdominal cavity pressure as we seal that off and prevent air from flowing through. And we'll look at a part of the larynx that will physically separate the respiratory from the digestive as we're continuing on with that swallowing process. Now, we've got 9 different cartilages that we need to know about as part of the larynx. And it's easiest to remember these as we start to compartmentalize them. 6 of these 9 are seen as pairs. The remaining 3 are unpaired cartilages. And as a general rule, the unpaired cartilages are going to have more of a protective role, physically protective, whereas the paired cartilages will play more of a role in the anatomy associated with sound production. And here's the entire apparatus that we're going to be looking at. So the first cartilage we want to look at is the thyroid cartilage, the largest of the 9. Picture the thyroid cartilage as looking like a shield. It projects off to the front in what we would call the Adam's apple. But if you trail that thyroid cartilage towards the rear, here's the Adam's apple projecting off the front, you will see that towards the rear, it is open to the back. So it does not complete a full ring. It is a protective shield over the front of the larynx. We'll be mentioning the role of the thyroid cartilage again as it associates with speech in just a moment once we look at the anatomy responsible for controlling the air. Just below it, we have our cricoid cartilage. The cricoid cartilage does form a full ring. It's a rather bulky cartilaginous ring. Now, from the front, if you were to palpate that anatomy, and run your fingers over the Adam's apple, and then move your finger down the front of the neck ever so slightly, you will start to feel these ridges of cartilage, these tracheal cartilages. This cricoid cartilage is going to sit in there just a little bit deeper, so you're going to have to move your fingers in a little bit deeper till it's almost uncomfortable. But once you run your finger up and over that cricoid cartilage, it will feel very similar to the more inferior tracheal cartilages. But unlike the tracheal cartilages, it does form a full protective ring posteriorly. The last of the unpaired is the epiglottis. It's a broad, flat, you'll often hear it referred to as almost spoon shape. Remember, as you swallow, we need to find some way to seal off that trachea and prevent food from entering the respiratory tract. That's the job of the epiglottis. Once you move into the voluntary phases of swallowing, muscles pull the epiglottis down, and by using the nature of its elastic cartilage, it covers up the opening to the trachea, allowing food to be directed down into the more posterior esophagus. So those are your three unpaired laryngeal cartilages, and they all take on some variety of protective mechanism. We look at the other 6 cartilages now. Remember, 3 pairs. We have our arytenoid cartilages, our cuniculate cartilages, and our cuneiform cartilages. Now, these are going to be the ones more so associated with sound production. We will look at vocal folds and a membrane that moves open and close over the opening to the respiratory tract, allowing varying degrees of air and moving over different tensions of those vocal folds to change the character of the sound that's being made. Our 3 pairs of cartilages that we look at now are directly associated with the vocal folds. You see, first we have this boomerang shape. Let me draw it. I'll circle this here in red there, and I will circle the same one in red there, and you can see how it changes position. That's our arytenoid cartilages. Attached to the tip of the arytenoid cartilages are our vocal and vestibular ligaments. The vocal ligaments being the 2 more medial, while the vestibular ligaments are more lateral, running parallel with it. But they attach onto the posterior aspect of the thyroid cartilage, the inside of the shield, so to speak, and the tip of the arytenoid cartilages, that boomerang-shaped cartilages. And as that arytenoid cartilage articulates back and forth, it changes the angle and tension on the vocal and vestibular ligaments, therefore opening and closing the opening down into the trachea. The other pairs of cartilages that we see here, first of all, let's look at the corniculate. Corniculate, it has a horn shape to it. Sits on top of our arytenoid cartilages, and it's going to be an attachment for some soft tissue and muscle. Right? If we want to move our arytenoid cartilage, we've got to have some means of articulating it, right? Corniculate cartilages sit right on top of the arytenoid. And then finally, we have our cuneiform cartilages that we typically don't see on a diagram such as this because they're more so embedded into the soft tissues. Here's where our cuneiform cartilages would wind up being, sitting more so into the soft tissue, just out from the corniculate cartilages. Now, of course, as you see the drawing on the top, that structure is not going to do a whole lot to change air flow. So we need to associate membranes with the vestibular and vocal ligaments. We have a thick membrane that's going to encompass each pair of vocal and vestibular ligaments, called the vocal folds, while the vestibular folds attach onto the vestibular ligament laterally, and the remaining walls of the larynx. So we can bring that open and close. We call that the rima glottis. And completely close down airflow down into the trachea. And as we open and close it again, we change the angle, we change the tension on the vocal folds. Therefore, we can manipulate the sound quality of the air that's flowing through it. Now we move down into the trachea, one step closer to our respiratory portion. Trachea is going to be referred to, as a layman's perspective, as the windpipe, a singular midline structure supported by cartilaginous rings, the tracheal cartilages. These are the ones I said you could palpate moving your fingers up and down the anterior surface of your neck. It'll feel like bumpy ridges. In between those tracheal cartilages, you have your annular ligaments. So if you feel the bumpy ridge, that's going to be your tracheal cartilages. The space in between is where you will find the annular ligaments. Now remember, these are not attached on the back. They are not complete rings. We refer to them sometimes as tracheal rings, as we call them tracheal cartilages, but they are not complete cartilaginous rings. Towards the posterior aspect, we have our trachealis muscle connecting the tips. Here's your tracheal cartilage, forming this C or horseshoe shape. The trachealis muscle spans the tip. So it's important to realize which way those muscle fibers are oriented. The muscle fibers are oriented horizontally. They run medial to lateral, not up and down the back of the trachea. And as these muscles contract now, we can slightly approximate the tips of our tracheal cartilages, closing down the diameter of our windpipe. Again, if we want to increase pressure in that tube, we're going to have to make that tube a little bit smaller. We continue down through the trachea till we get to a structure called the carina. You don't see it from the outside. It's an internal projection. Basically, it would project up and would separate our trachea into a left and a right main bronchi, sometimes called the primary bronchi. As we move from there, you will see that the main bronchi will divide up into smaller structures. Those smaller structures will divide up into even smaller structures again. Not that undifferent to the way you envisioned large arteries dividing into smaller arteries and smaller arteries dividing into arterioles. Except this time, obviously, carrying air, not blood. You will see some resources say that the main bronchi divide into secondary bronchi, which then divide into tertiary bronchi. We're going to try and get away from those terms should you come across them. Main bronchi will divide into lobar bronchi. Lobar bronchi will divide into segmental bronchi. Once we look at the gross anatomy of the lungs here in a little bit, you will see that each lobe is divided up into a particular number of lobes. Each lobe of each lung is then divided up into a particular number of segments. You have two main bronchi because you have two lungs, a left and a right. You are going to have 5 lobar bronchi because as a total, you have 5 lobes, 3 in one lung, 2 in the other. They will further divide up into segmental bronchi, which are consistent with the number of segments in each lobe. So using these particular set of terms helps reinforce the other anatomy that we'll look at in just a little bit. And already I have to stress, memorize these in order. Trachea, main bronchi, lobar bronchi, segmental bronchi. You're moving in the sequence as they divide. The bronchial tree will continue to divide in such a manner. When we see the segmental bronchi finally divide into bronchioles. These are going to have a high component of smooth muscle associated with them. Remember the arterioles? They were the blood vessels that had the greatest capacity to constrict and dilate. The bronchioles are going to have the greatest capacity to change their diameter in a similar manner. We talked about blood vessels changing their diameter, which therefore change the resistance to flow. We are going to count on these bronchioles to change their diameter in order to vary the resistance of air that passes through. You are in a time of exercise, for example. You increase your respiration rate because you need to get a greater capacity for gas exchange. The last thing you're going to want to get is resistance of air as it moves into and out of the lungs. So we increase the diameter of these bronchioles so air will flow into and out of the lungs just a little bit easier. Rather than vasoconstriction and vasodilation, now that we use those terms with vascular and cardio, these are bronchioconstriction and bronchiodilation. So trachea divide into main bronchi. The main bronchi divide into lobar bronchi. The lobar bronchi divide into segmental bronchi, which divides into bronchioles. The bronchioles divide into terminal bronchioles. Now take your cue from the word terminal here. Terminal pretty much means end of the road, right? This is not the end of the road completely, but it is the last portion of our conductive anatomy. Remember, we had divided up this respiratory system into a conductive and a respiratory portion. The conductive only moved air into and out of the lungs. The respiratory portion now started to get more involved with direct gas exchange. This is the end of the road for the conductive portion. As we move on and continue through the respiratory tree, we move into our respiratory portion of it. Terminal bronchioles divide into respiratory bronchioles. Respiratory bronchioles divide into alveolar ducts. And then finally, the alveolar ducts divide into alveoli. So the respiratory bronchioles, alveolar ducts, and alveoli themselves are all respiratory portion of our respiratory system. However, the alveoli are the only place where we have the membranes where gases will pass through. These alveoli are blind sacs. So we went through all of this network to get air into the deep portions of the lungs. This is where we needed to get it. These blind sacs are going to be highly vascularized, and we will see gases move across the membranes of these alveolar sacs. You might recall looking at these in the lab as part of your A&P1 study. Very cavernous tissue with extremely thin membranes. Simple squamous epithelial tissue for the most part. And we actually have two types of cells associated with the alveoli. We had type 1 alveolar cells. Now these are going to be the ones where gases go through. Simple squamous epithelial tissue, broad, flat, thin, and ideal for transport of gases at a high rate of speed. But also associated with the alveoli are these modified cuboidal cells. These are going to produce a fluid called a pulmonary surfactant. That surfactant is going to line the inside of the alveolar. It's going to create a moist membrane to further promote transport across it, and it's going to decrease surface tension within the alveoli, therefore preventing any collapse of that structure. If we look at that on a diagram, we will see these broad, thin type 1 alveolar cells. Nice, broad, flat surface. Perfect for gas exchange. But then we will get these modified cuboidal cells producing that surfactant fluid that will line the inside of the alveoli. The respiratory membrane itself is actually composed of 3 portions. Now, when we get into gas exchange here as a separate lecture, we are going to be talking about diffusion and rates of diffusion. It's important to learn your transport topics. Back when we did that as part of AMP1, we emphasized that this was a topic that was going to just linger with you, membrane transport. Back when we did membrane transport then, we were only talking about transport across a cellular membrane. So there were certain variables back then which simply didn't apply. One of those variables was distance traveled. We said that the rule was the shorter the distance the solutes have to travel, the higher the rate of diffusion. But because we were just dealing with a cell, we said at the time that we don't see a whole lot of variability between cell membrane thickness, so we could disregard it as a variable then. But when we are talking about diffusion in this context, distance traveled is critical, because we could potentially be dealing with distances much thicker than a plasma membrane. You will see that the respiratory membrane does everything it possibly can to minimize the distance that these gases have to travel. We have our alveolar type 1 cell as part of our alveoli. We have the capillary wall, right, one cell thick each. Remember, we're doing this exchange with the blood. And connecting those two membranes together, connecting the alveolar cell directly with the cells of the capillary wall, we have this basement membrane. So as gases move from the air that you just breathed, or oxygen from the air you just breathed in, through the alveolar cell, through the capillary wall, and through the basement membrane in between, you go from the air into the blood. We can't do much about the thickness of the capillary wall. We likewise can't do much with the thickness of the type 1 alveolar cell. Those are going to be constants. As long as we keep those two membranes in complete contact with each other, we will always ensure that the distance that we have for that diffusion to occur is always going to be minimal as possible. So we have our wall of the capillary, we have the wall of our type 1 alveolar cell, and then connecting the two is a very thin basement membrane. And by anchoring those together, the distance across the structures that we have to move the gases is always going to be as small as possible. But we will talk a little bit more about that respiratory membrane once we move into gas exchange. Now, moving away from our bronchial tree, we've kind of done with the anatomy now to get air into and out of the lungs. We're going to have to look at gross lung anatomy now and the surrounding cavities in which we find the lung tissue. You're familiar with the membranous cavities of the body because we have talked about those before. We talked about them generally in AMP1, and we talked about them as they relate to the heart with our pericardial cavity. Well, this time we move into the cavities that surround the lungs, the pleural cavities. Now, a lot of the terminology is going to be very similar. You should know by now that a membranous cavity is made up of two membranes, a visceral layer and a parietal layer. Except now that they're associated with the lungs, we call them pleura. So we have a visceral pleura that sits directly on the surface of the lung, and we have a parietal pleura, which will line the inside of the thoracic cage. The pleural cavity is only the space found in between. Our visceral pleura sitting right on the lungs, our parietal pleura sitting just out from it. Therefore, the space in between is only what we consider the pleural cavity. Remember, the pleural cavity surrounds the lungs. The lungs are not found in the pleural cavity. We'll do a separate lecture on ventilation. At that time, we will discuss how this pleural cavity connects the dots, so to speak. Because as you breathe in and out, you have this large dome-shaped muscle underneath called the diaphragm, and you have the superficial surrounding rib cage. The diaphragm and the rib cage, you have mechanical control over. You contract the diaphragm and it pulls down. You have muscles attached to the rib cage to lift it up and expand it. However, none of that anatomy is physically connected to the lung tissue itself. So the question when we get to ventilation will be, how does the mechanics of the thoracic cage translate into true lung tissue expansion and contraction? And the secret between both of those being functionally connected is going to be the presence of the intact pleural cavity. So once we get into that topic at that time, make sure you understand the structure of this membranous cavity, because understanding it is going to be critical to knowing how we actually get air ventilated into and out of the lungs. You will see with the lungs, we have a left and a right, obviously, a pointed surface at the top, which we consider the apex. Now, the left and the right lungs are not going to be symmetrical structurally. We mentioned lobes earlier. You have 5 lobes. The right lung has 3. The left lung has 2. And because of the asymmetry in the number of lobes we have, obviously we're going to have asymmetry in the fissures that separate them. The right lung has a horizontal fissure and an oblique fissure. The left lung only has the oblique fissure. We see other asymmetries between the left and right lungs due to the slight asymmetry that we had with the heart. Remember, the apex of the heart kind of kicks off to the left. Because of that, the lung tissue has to accommodate it. We have a cardiac notch on that left lung to kind of make space, if you will, for the apex of the heart. If we turn the heart over and look at the medial surface, we will also see an indented portion called a cardiac impression. Again, making room for the mass of the heart that extends more so off to that left side. On the medial side of each lung, we have an opening called the hilum. Moving into and out of that hole is a number of blood vessels, arteries and veins, pulmonary arteries, pulmonary veins, and our left and right main bronchi. That collection of anatomy is called the root of the lung. Please don't get the hilum confused with the root of the lung. Some students are going to assume that they are both different names for the same thing. And it's not like we don't see that pop up on occasion, right? But in this case, the hilum is part of the lung. It is the opening in the lung, which the root passes through. The root is the collection of everything that goes through the hilum, the pulmonary arteries and veins, and the main bronchi. Dividing up each lobe is any number of segments. Now, I'm not going to make you responsible for knowing the names of each of the segments, but many of them are named using directional terms. You have superior segment, lateral basal segment, anterior basal segment. So we name our segments very often using directional terms. But to get back to what we had earlier, remember, we would have had 2 primary bronchi because we had 2 lungs. we would have had 5 lobar bronchi, 3 going to the right lung, because we have 3 lobes in the right lung, 2 lobar bronchi going to the left lung because we have 2 lobes in the left lung. Each of those lobar bronchi will then divide up into segmental bronchi relative to how many segments happens to be in that particular lobe. So just to give some relevance to why they are named what they're named. So here in this section, we just strictly dealt with anatomy. We introduced a couple of physiological terms that we're going to get into, like gas exchange, gas transport, and ventilation. But we're going to include those in different lectures. I wanted to get all of the respiratory anatomy out of the way first, so then when we get into the function, we can use our anatomical terms as part of our language to describe what we're talking about. So just like with any other anatomy, you're really left with memorizing this, is what I would recommend. But just like I recommend it with cardio, whenever you have a sequence, memorize it as a sequence. That way, if test time you happen to mentally lapse on a particular term, if you know the other sequences, you can start to eliminate possibilities as answers. So look at this lecture first, then we'll move into the more physiological discussions of gas exchange and ventilation. Thank you.